Howdy, my name's Aaron Boster, and I'm the Systems Medical Chief of Neuroimmunology and the Director of the MS Center at Ohio Health here in Columbus, Ohio.
The following audio is part of a certified educational activity titled Harnessing the Full Potential of Disease-Modifying Therapy Mechanisms of Action to Improve Outcomes in Multiple Sclerosis. Access the entire activity and complete the post-test at www.peerreviewpress.com/KSZ. Downloadable slides and practice aids are also available.
I'm here today to talk about the present state and the future direction of disease-modifying therapies for relapsing forms of multiple sclerosis. MS is an autoimmune condition. It's inflammatory and neurodegenerative, affecting the central nervous system. So what do all those words mean? In order to understand MS, we start by talking about the immune system. The immune system is made up of a bunch of little white blood cells. They're born inside the bone marrow. And when they leave the bone marrow, they go to school at T-Cell University up in the thymus. Now, T-Cell University is a very weird school. First of all, it's free to get in, and there's only one class. The class is, can you differentiate a self cell from a foreign invader? Now, as long as you can do that, you graduate. And the only occupation is soldier. And so all the cells that graduate from T-Cell University, they tool around the human body doing a tour of duty. And if they see one of their O cells, they give it a high five. If they see a foreign invader, they stop what they're doing. They take a picture of the invader, which they keep for the life of the human. They call all their friends over, and then they stomp it. Unfortunately, sometimes the immune system makes an error in judgment. And one of these very poor students at T-Cell University sneaks by, fails the test. Now you have a soldier that gets confused. And when he does his tour of duty, he sees what he thinks is a foreign invader. It's really part of yourself. And he does what he was trained to do. He takes a picture of it, he stomps on it, calls his friends over. Unfortunately, that photograph isn't of a foreign invader, it's a part of you. And this is really the underpinnings of what we call autoimmunity. Multiple sclerosis is an autoimmune process where the immune system inappropriately attacks the brain and spinal cord. Now that's a problem because the brain is the holiest of holies. It's the supercomputer that runs the whole body. And the spinal cord is the superhighway that takes all that information to and fro. It stands to reason that the clinical presentations of MS are varied, anything involving the central nervous system. I'd like to tell you a story about a patient named Matt. And I'd like to use this story to share with you how we talk about MS, goals of treatment, the options, and how as a group, as a team, we make a decision. So let me tell you a little bit about Matt. He's a young guy, 28 years old. He's a biology teacher during the day, and he drives for one of these ride-share companies at night. He does this on weekends as well. And one Friday night, he was out driving folks around, and his right eye was bothering him. And he would rub it, and it didn't really seem to get better. But he had been burning the candle at both ends. He was exhausted, and he just assumed that's why he had blurred vision. So he goes to bed and wakes up the next day. Unfortunately, it was worse. He was really having trouble seeing out of his eye. And in fact, when he moved his eyeball around, it actually hurt. He put some eye drops in his eye, and it didn't help. And by the next day, his vision had gotten so poor that when he looked just with his right eye, he really couldn't see the television very clearly. And he noticed that colors looked weird. He mentioned this to his roommate, who kind of flipped out and said, "We're going to the urgent care." And so now Matt finds himself in an urgent care where he's seen by a resident and then by an attending physician. And what do they uncover? Well, the visual acuity in his left eye was crystal clear, 20/20. But the visual acuity in his right eye had taken a hit. It's now 20/50. During a swing test, he had an afferent pupillary defect. And he described orbital pain when he moved his eye around. So they didn't see anything else, but they had concerns. I mean, they were finding physical exam findings in a young man that was otherwise healthy, and so they opted to send the gentleman to go to the ER. Now, in the emergency department, they put his head in a scanner, and he got an MRI of his brain, and he got an MRI of his orbits. What we saw wasn't terribly happy. His optic nerve on the right side lit up like a Christmas tree, and he had spots in his brain. So he had spots in periventricular and in juxtacortical locations, and some of them enhanced after we gave contrast. Based on all of this, there was a high concern that this young man might in fact have multiple sclerosis. The folks in the ER had the wherewithal to start high-dose corticosteroids, high-dose oral prednisone, and they sent him promptly to be seen at our NMS center in clinic. They ordered a couple laboratories, and they set him up to be seen lickety-split. So now Matt comes in to see us in clinic. He says, my eye doesn't hurt when I move it around anymore. He can see the television better, and when we test his visual acuity, it wasn't back to 20/20. It was back to 20/30, although he felt much better about it. Now, when we did a careful neurological examination, we in fact picked up a couple very subtle things that might have been missed in the ER. First of all, when he smiles, his nasolabial fold on one side isn't what it is on the other. During tracking of extraocular movements, he in fact has some sustained nystagmus with horizontal gaze in his right eye. And so now we're becoming even more sensitized that something ain't right. Looking at his baseline laboratories, it was clear he didn't have an infection, his liver worked, his kidneys worked, and there was really nothing there to speak of. When you put all this together, you've got a young man who's Caucasian with no significant past medical history, who presents with a rather classic optic neuritis. You find, in fact, that he has brainstem symptoms, and that would suggest that, in fact, there was more than one thing going on. When you apply that clinical history with the exam findings and with his MRI, using 2010 revised McDonald criteria, this young man has multiple sclerosis. And so now I have to turn to Matt, and I have to tell him his diagnosis. I always like to explain to people there's 5 criteria that we used. Your story, the optic neuritis, your exam, what we saw that buttressed your story, the MRI, and really that's all that we needed. We don't need to get a lumbar puncture for spinal fluid, and we've proven it's not other things. And so I explained that I felt very, very confident in his diagnosis. Everyone takes an MS diagnosis differently, and Matt was shell-shocked. He kind of stared at me blankly, trying not to cry, and he said, but I'm not a woman, and this is a disease of women. Now, when you see that a human being is not grappling with the diagnosis, it is not the appropriate time to jump into a long discussion about disease-modifying therapy. And so I told him, look, this is too much. Today I need you to understand how I came up with the diagnosis. And in fact, I'm going to bring you back in a couple weeks, and I want to sit down with you at the end of my workday, and I'm going to start to talk to you about how we're going to beat this disease. And so I sent Matt home, and I wanted him to just absorb what I had told him. I said, I need you to come back in 2 weeks, and then we're going to spend some time talking about these therapies. Matt returns a little more composed. He's done some Dr. Google internet searches, and he's coming in with a list of questions. And he starts off saying, I need to talk about these side effects. And I said, whoa, partner, you're kind of getting ahead of me. What I proposed to Matt, and what I am fond of doing, was starting off by talking just about how the drugs work. I said, let me spend some time discussing this with you because there's a lot to go over. We'll start our discussion talking about some of the so-called first-line therapies. These tend to be self-administered injections. Glutamer acetate, 4 amino acids in a random order. But the ratios mimic myelin. And so in essence, what you're doing with glutamer acetate is you inject what looks like fake myelin under the skin, and you present it to your immune system and say, hey, come here, look at this. See it? And what happens is the immune system becomes bored. And so when it sees the actual real target, instead of getting fired up and attacking it, it says, eh, and it actually takes, instead of a pro-inflammatory cytokine profile, sort of an anti-inflammatory picture. And that slows down MS. We're then going to shift our attention to another set of shots, and these are the interferon beta products. And there's several different flavors of interferon beta products. But they all work in a similar fashion. Again, these are self-administered injections. When you add interferon to the blood-brain barrier, it prevents some of those autoreactive cells from crossing and getting over into the central compartment. And so through a different mechanism, interferon beta products can slow down MS by denying those autoreactive cells access to the central compartment. I'm now going to shift gears and spend some time talking to Matt about oral medicines, of which there are 3. The first one we'll talk about is fingolimod. Now, fingolimod is a very, very unusual medicine, and it also causes white blood cells to not be able to gain access to the brain, but it does it in a very different way. What happens is fingolimod ends up trapping about 80% of white blood cells into the lymphatics, into the lymph nodes, and it traps them. You don't kill them, you just sequester them and they can't leave. Now, in doing so, you prevent the cells from gaining access back into the bloodstream. And if they can't get in the bloodstream, they can't cross the blood-brain barrier and get in the brain. And so through a different mechanism, fingolimod prevents those cells from gaining access to the central compartment. What's interesting about fingolimod is if you stop the drug, the cells are re-released. The next pill that I want to talk about is called teriflunomide. And teriflunomide is an interesting compound in and of itself. When you have a cell, any cell, including an immune cell, it makes a copy of itself before it dies. And that way the cells can maintain a cell line indefinitely. And when you are resting and relaxing and there's no active inflammation, you do that through what's called a salvage pathway, and it's very low and slow. However, when you have active inflammation, you sort of need an army like right now. So you use a different pathway, an accelerated pathway, so you can quickly build the building blocks of proteins and make more cells. When you take teriflunomide, it blocks an enzyme which prohibits the cellular machinery from being able to rapidly make new cells. Interestingly, that salvage pathway, the original path I talked about, that's not interrupted. And so really this drug doesn't kill cells, but it prevents the ability to make them too quick. And in doing so, you prevent the immune system from being overly reactive. And as a result, you end up slowing down MS. That's teriflunomide. The third pill that I would like to talk about is called dimethylfumarate. Yet again, another unusual mechanism of action. Now, the way dimethylfumarate works, and this is a pill that you take twice a day, is it literally tricks the cell into thinking it's under oxidative stress. When a cell thinks it's under oxidative stress, it creates a cascade of antioxidants which end up slowing down MS disease activity. And so it's by tricking the cell into thinking it's under oxidative stress that it results in good stuff that slows down multiple sclerosis. We've talked about shots, we've talked about pills. Now I want to talk about monoclonal antibodies. A monoclonal antibody is rather interesting. An antibody is like a key. A key unlocks a specific lock. It only fits with one thing. Our bodies make antibodies, but you can also engineer an antibody in a laboratory. And so monoclonal antibodies are engineered keys that have very specific targets. Natalizumab is an infusion, and it's given once a month. And what it does goes back to that blood-brain barrier. Well, when you put natalizumab on it, nothing can get through. And in doing so, you deny those autoreactive cells access to their target, and it slows down the disease process. The next monoclonal antibody that I'll talk about is called alemtuzumab. It's another smart bomb or a key that unlocks a specific target, but it doesn't do anything to the blood-brain barrier. It actually causes cell death to certain cells. If you have a cell that expresses CD52, this drug binds to it and causes it to die. So which cells express CD52? Well, out of all the white blood cells, most don't. But adult lymphocytes do, and these are the B and the T cells. You don't mess with the other cell lines all that much at all, and you don't mess with the baby cells, the pluripotent stem cells. But you knock out a population of adult B and T cells, and then it seems that you force them to grow back in a nicer fashion. And in doing so, it slows down MS. The next monoclonal antibody is a very unusual one. It's actually an injection, a shot. And it targets the alpha subunit of something called IL-2. What does that mean? Well, I want you to think of MS as a series of machines, starting with inflammation that results in damage to the cells. And really what this drug is doing is it's breaking part of that machinery. And in doing so, you disallow cells to expand and then to get riled up and to attack. And so by interfering with the IL-2 subunit, you end up breaking the machinery that leads to the pathogenesis of MS. And that's how we think that it slows down the disease process. The last monoclonal antibody that I would like to talk about is called ocrelizumab. It only binds to cells that express CD20. CD20 is expressed on adult B cells, not T cells and not other cell lines, specifically adult lymphocytes. It doesn't affect the pre-cells, and it doesn't affect the plasma cells. There's a narrow window. Now, we think commonly of MS as a T-cell driven disease. The T-cells are attacking you. But it turns out that you need B cells to get the T-cells all fired up. It's called co-stimulation. I tell Matt, I always think of it as like two boys that are going to fight after high school. So they say, I'm going to meet you at 3:30. And they show up to fight with 6 of their best friends. In this analogy, the T cell is the kid that's going to fight, and all the friends are the B cells. Now, what happens if one kid shows up and none of his friends are there? Well, he leaves. He doesn't fight that day. In a similar fashion, when we give a patient ocrelizumab and we knock out all the adult B cells, it makes it very hard for the T cell to get activated, and then it doesn't attack. That is a tremendous amount of information for someone who's not indoctrinated in this field to become comfortable. And so, after sharing this with him, I said, look, we now need to take yet another break. I want you to go home. I want you to think about what I've told you. I'm going to give you some information to kind of peruse in your mind. And then I'm going to have you come back yet again. You have to come back in 2 more weeks. I'll meet you after my work day. And I want to take next steps and talk a bit more. I now see Matt for the 3rd time. The first visit, he was in shell shock. I gave him a diagnosis of a disease, quite frankly, that he wasn't very familiar with. That in and of itself takes some time to digest. I saw him back a couple weeks later, and we started to broach the topic of disease modification. It became very clear to him that there's a bunch of different medicines, and they all work differently. And really, I wanted to spend that time talking about how they worked. Now he comes back for a 3rd time. And now he's more ready to sit down with me and talk about details. He's done a little reading, and now he's ready to engage in a higher level conversation. And the focus of this visit is really on discussing the efficacy and the safety of the therapy so that he can get ready to make a really important decision. When we get into talking about goals of treatment for relapsing MS, I think it's easiest to think about it in 3 categories. Number 1, we have to deal with relapses. And at bare minimum, we want to decrease the frequency and severity of relapses. The second goal is to decrease the MRI activity. Now, if you have an attack, that's bad for you. But I'll tell you something. If you have new spots on your MRI, prognostically, it's just as bad. And so cleaning up the MRI and preventing new spots from occurring is also very, very important. Thirdly, and arguably the most important, is to slow down or hopefully stop progression of disease. Now, if we, for a block of time, have no attacks, we have no new spots on MRI, and we have no disability progression, we call that no evidence of disease activity. I have to explain to patients that's a very, very high bar, and none of the medicines are going to do that all the time. But I also tell them we have to say our goals out loud. And that way, if nothing else, we know when we're hitting them and when we're falling just shy. And so it's important to understand that not all drugs are equally efficacious. On the screen here, you see a list of some of the so-called first-line medicines, a lot of the injections that I talked about earlier. And as you look at those 3 data points, they can clean up relapses and clean up MRI. But not every one of them has been shown to decrease disability progression in a statistically significant fashion. And I'll share with you that's very, very important. And so that's going to factor into some of our decision making. Talking about the tolerability of drugs is very important. MS is a disease you'll die with, not from. And if we control your disease process and you are a miserable human being in the process, we aren't doing the best job that we could do. And so it's appropriate not just to talk about the efficacy of the medicine, but the safety and tolerability as well. And so we'll start talking about glutaramine acetate. This is an injection that you give yourself, and you do it 3 times a week. And so you can have an injection reaction, and some people describe it as like a welt or a bee sting. And rarely, less than 10% of the time, someone will inject and they'll have a scary systemic reaction where they'll get short of breath, they'll have chest pressure, they start sweating, they get anxious, they're not sure if maybe it's a heart attack or maybe it's a panic attack. It's actually just an immune response. It's safe but scary, and so I like to warn patients about it. I tell them, if you're out shoveling snow and have crushing chest pain, to the ER. But if you're lazing around in your lazy boy recliner and you give yourself an injection and this happens, just call me. The third thing that bears mentioning is that if you inject your skin year after year, time after time, you can start to wear down the fat underneath the skin. That's called lipoatrophy, and that's another side effect of taking this medicine. Shifting gears to the interferons, which are also injections, we have a different category of symptoms. The biggest thing that I like to share with patients is that they can have flu-like symptoms. Interferon got its name because it was found to interfere with viruses. And in fact, when you have a virus or a cold and you feel yucky, that's not the virus, it's actually your body making interferon that kind of makes you feel yucky. Well, if you bottle that in a syringe and inject it into you, it stands to reason that you can feel flu-like. And unfortunately, many patients experience flu-like symptoms associated with their interferon injections. Interferon is metabolized by your liver, and sometimes it can cause elevation of liver enzymes. And also, very rarely as a side effect, interferons can lower the white count. And so these are things that we want to monitor. Before we get started with interferon, we recommend that you check liver enzymes and a CBC. We also recommend that you look at thyroid because rarely interferons can cause hypothyroidism. When you're on interferon, it's a good idea to check those. We typically do it every 3 months. As we become comfortable, we might extend that out to every 6 months. Shifting gears, we're now talking about pills. The first pill we'll talk about is fingolimod. And fingolimod achieved its FDA approval with a series of clinical trials, and I want to review some of them briefly with you. The Freedoms 1 trial pitted fingolimod against dummy drug or placebo. And as compared to placebo, it decreased the frequency of attacks by over half. It decreased new spots on the MRI by 3/4, and it shut down enhancing lesions by 82%. Very, very robust results. We repeated the trial with the Freedoms 2, and it had very similar results with the exception that Freedoms 1 slowed down disability progression by about 30%, whereas Freedoms 2 didn't find a statistically significant result. Starting fingolimod, it arguably can be a bit of a pain. There's a bunch of things that we have to check. I call them safety hoops. We want to jump through the safety hoops before we can feel comfortable taking the drug. We have to make sure that someone has a positive VZV titer, that they mount a response to varicella, and so we can check that in the blood. We want to get baseline liver enzymes and white blood cell counts to make sure they're copacetic and normal before we start. And we need to do an examination of the fundus in the back of the eye to make sure that there isn't any swelling. Once we've done those things, we can then participate in what I refer to as the first dose monitoring. It's recommended by the FDA that the first day you take the pill that you're monitored, we get an EKG to make sure that you don't have a long QT interval, and then for the next 6 hours, we check vital signs every hour. Most people will drop their heart rate about 20%, which is generally not clinically significant, and nonetheless, we want to be very, very safe with patients. And I share with patients, we don't have a second first dose effect, it's just that first day. Now, after you get through all those safety hoops, what are you doing? Well, we're going to check liver enzymes, because rarely this drug can make your liver enzymes go way up. And we're going to watch the blood pressure, because rarely it'll raise the blood pressure. We have to check the back of the eye one more time at least. There's a 0.4% risk that it would cause swelling or macular edema. And the highest risk is around 3 to 4 months. And so in the first year, we're going to check a couple times to make sure we don't have that problem. We now shift our attention to teriflunomide. And here we see data from 2 clinical trials. Looking at the high dose of teriflunomide as compared to placebo, we see that it decreases the frequency of attacks by about 34%. It decreases the lesions on the MRI. Now, when you look at 3-month disability progression, this drug decreased that as compared to placebo by about 30%. The side effect profile of teriflunomide includes a couple things that we want to keep in mind. Number one, this drug is metabolized by your liver, and rarely it can drive your liver enzymes up. And so before we get started, we want to check it to make sure liver enzymes are normal. And then we're going to check it very carefully. In fact, in the first 6 months, we're going to check liver enzymes once a month. After that, then we can check it every 3 to 6 months like we do for most drugs. This drug can cause headache and rarely diarrhea, and in my experience, this typically goes away in the first couple months. It also can cause alopecia, which is a doctor term for thinning hair. If it happens, it's only in about 13% of patients. It occurs at 2 months, and it typically goes away whether or not you stop the drug by 6 months. This drug, when we used to do pregnancy categories, was considered pregnancy category X. And so we want to make sure that patients aren't pregnant before starting it and that they use appropriate contraception. The FDA suggested that we check a TB test before we start taking the drug. Also, very rarely, the drug can elevate the blood pressure, and so we want to check blood pressure before we get started. The third pill that we'll talk about is dimethyl fumarate. Dimethyl fumarate is a pill that you take twice a day, and we ran 2 clinical trials where we pitted this drug twice a day against dummy drug twice a day. And as compared to dummy drug, when you look at the defined trial, we decreased the frequency of attacks by over half. Impressive result. We also handsomely cleaned up the MRI. When you compare the 2 clinical trials, define and confirm, they had very similar results with these metrics. Although one of the trials, define, showed a statistically significant drop in disability progression, and that was not recapitulated in the confirmed trial. The side effect profile of dimethyl fumarate really includes 2 main things: facial flushing and GI symptoms. Both of these are infrequent, and if they occur, they tend to go away after a couple months. But I like to warn patients so that they're not surprised. Abdominal pain, nausea, and diarrhea can be seen as well, and oftentimes these will go away if people can be persistent. We found that if patients don't take the drug at regular times and don't take the drug with food, they're more apt to have flushing and GI symptoms. Before we get started taking dimethyl fumarate, we want to check a CBC, because rarely the drug will drop your white count, and so you need to know where you start from. And like many drugs, this drug is metabolized by your liver, and so we want to get baseline LFTs before we get started. When you're on drug, we recommend checking a CBC and LFTs periodically. Shifting our attention to monoclonal antibodies, the data for natalizumab is compelling. In the AFFIRM trial, we compared natalizumab to dummy drug, placebo. And what we see here, compared to dummy drug, natalizumab decreased the frequency of attacks by 68%, pretty big number. If you look at new or enlarged T2 lesions or contrast-enhancing lesions, again, a very, very robust result. In this trial, we looked at 3-month disability progression, and as compared to placebo, natalizumab decreased the likelihood by 42%. Again, a very, very robust number. In considering natalizumab, there's one major concern, and it's the potential risk of a very rare but potentially fatal infection. And so there's a virus that about half of adult humans have, called the JC virus. And if you happen to have the JC virus and you happen to take natalizumab, there's a very small risk of developing an infection called PML. That's a brain infection that sometimes can be fatal, and so we take that very seriously. Getting ready to take natalizumab involves checking the status of your JC virus. We also want to look at your liver enzymes and your white count, and it's a very important idea to have an MRI before you start this drug so that you can always compare back. The next monoclonal antibody to discuss is alemtuzumab, and there were 2 clinical trials. The first one was CARE-MS-1. In the CARE-MS-1 trial, we enrolled treatment-naive patients that had never been on drug before, and they were randomly assigned to either receive alemtuzumab or the standard of care, in this case, interferon beta-1a TI weak. As compared to standard of care, the alemtuzumab-treated patients had less attacks. In fact, it decreased it by over 50%, a very robust result. We also see that it cleaned up the MRI, both for new and enlarged T2 lesions as well as contrast. In the CARE-MS-2 trial, it was the same design. Patients either received alemtuzumab or interferon, but these patients were treatment refractory. They had already been on a drug and suffered a relapse. Now, in this treatment refractory population, we see that those treated with alemtuzumab, again, decreased the frequency of attacks by almost 50%. And again, we see that it cleaned up the MRI, both for new and enlarged lesions and for contrast-enhancing lesions. Here, we see a rather robust effect in decreasing 6-month disability progression, and this time it was statistically significant in this treatment refractory population. Alemtuzumab is a very complex drug, and when I think about the side effects, I typically divide them into 3 categories. The first is infusion reactions. In fact, 93% of patients receiving this drug experienced an infusion reaction, and you can kind of look through and pick out the ones that are relevant. In order to take this drug, we have to check a lot of different things, because the second category is it can cause autoimmunity. And so there's a risk for autoimmunity with thyroid, with your platelets, and also with kidney function. And so before we get started, we have to check all of those so that we know the playing field. We also recommend that patients have a screen to make sure they don't have any opportunistic infections or things that would suppress their immune response. And we want them to have a skin exam because of a very, very rare risk of skin cancer, melanoma. When we infuse alemtuzumab, there's a high likelihood of infusion reactions. And so we give people per the label, a dose of high-dose corticosteroids before the infusions for the first 3 of the 5. We also want to prophylax for at least 2 months against the outbreak of herpetic infections. And so for at least the first 2 months, until the CD4 count crests above 200, we typically place people on acyclovir as a protective agent. Shifting gears yet again to the injected monoclonal antibody daclizumab, this phase 2 trial compared the drug against placebo. And what we see is, as compared to placebo, a very handsome reduction, over 50%, in relapses. We also see a significant reduction in new or enlarged T2 lesions or in contrast-enhancing lesions. Lastly, we see a very large reduction in 3-month confirmed disability progression. Here we see a phase 3 trial where we pitted daclizumab against intramuscular interferon beta-1a, an active comparator. And as compared to the interferon product, the patients receiving daclizumab had a statistically significant decrease in their relapse rate by about 45%. Again, we see that compared to interferon, daclizumab cleaned up the MRI quite handsomely. And whereas it didn't reach statistical significance in its ability to decrease 3-month confirmed disability progression, we saw a statistically significant decrease in 6-month disability progression with daclizumab. The largest side effects that need to be considered with daclizumab are really 2. It can raise the liver enzymes, and it can also cause skin reactions. And so both of these need to be monitored. Before you start taking this drug, we want to make sure that you're not immunosuppressed. And so we're going to send a couple screens to look for hepatitis infections, and we're going to make sure you don't have TB. And we want to check your liver enzymes. The last monoclonal antibody to discuss is ocrelizumab. In paired sister trials, OPERA-1 and OPERA-2, we compared ocrelizumab against an active comparator, again, interferon beta-1a TI weak. As compared to interferon, patients receiving ocrelizumab had just under a 50% reduction than annualized relapse rate. They had a handsome reduction in both new and large T2 lesions, as well as in contrast-enhancing lesions. And we saw a statistically and clinically significant reduction in both the 3-month and in the 6-month confirmed disability progression. In order to take ocrelizumab, we want to screen for hepatitis, because in a different drug in the same class, we have seen reactivation of Hep B. There are risks of infusion reactions, and so we like to pre-medicate before we give you the infusion with a little bit of steroids and some antihistamines. And we monitor the patients during the infusions to help minimize that. Long term, we want to keep in mind that there may be an imbalance in the risk of breast cancer. And so as a result, we recommend that women participate in standard breast screening, meaning monthly self-exams, and also making sure you get your mammograms. And that way we can keep people safe moving forward. We had not 1, not 2, but 3 separate visits to help Matt grapple with his diagnosis, understand the disease, set goals, both for life and for treatment. And now we need to make a group decision. And so I told him, we're almost ready. We're going to get a couple tests. I'm going to send you home with a couple pieces of information, and then I'm going to bring you back. And when you come back, I need you to be able to answer the following questions. How do you want to take your medicine? What route of administration? What is your risk aversion, and what kind of risk are you willing to accept? Because I can't have you miserable taking your drug. Thinking about your lifestyle, I need you to consider how frequently you're going to take a therapy and how difficult it would be to get your lab monitoring. And again, I really want you to think about your treatment goals. And so Matt and I get back together one last time. Matt is now charged with information on what this autoimmune condition is. He has a better understanding of how the disease-modifying therapies work, their efficacy, and also their safety. And he sits down, and he immediately has a couple questions. He said, now I went all over the stuff that you gave me, all right? And I also did my own research. And I actually read about a bunch of new cutting-edge investigational therapies, and you didn't talk to me about that at all. Also, because I'm really excited about some of these newfangled therapies that are being studied, do you think that I should maybe wait starting your drugs until we see where those end up? Now, I did feel comfortable talking about what's coming. And there are several disease-modifying therapies that are being tested in phase 3. And so there are, in fact, several different second-generation S1P receptors, like fingolimod, siponimod, ponesimod, to name a few. We also have a new, fully humanized anti-CD20, which would be kind of similar to ocrelizumab. But I told Matt, that's not the focus. When we diagnose you with MS, we open the books, and we look at what's currently available. And we need to pick a drug in the now. Now, things in the future we can look at. And as drugs come out, of course you and I are going to talk about it. But I counseled him very strongly that we have to pick amongst the options that we have. We can't wait for something that might happen. Here's Matt's laboratory and examination workup. The vast majority is very reassuring. But I want to spend a few moments talking about the JC virus status. We see that he's a positive, so what does that mean? If you have relapsing MS, and if you're going to take natalizumab, we have to grapple with the risk profile of developing PML. And there's really 3 factors, or maybe 4 factors, that we're going to consider in Matt. The first one is, have you been exposed to the virus? And by testing his blood, we see that yes, he has. He has been exposed to the virus. If you've been exposed to the virus, the second question is, have you come in contact in the past with immunosuppressants? If you have, it actually increases the likelihood quite substantially. Now, then we have to ask ourselves, if you've never been exposed to immunosuppressants, what was the optic density, the titer, the index? And different levels of index increase or decrease the risk. Now, once you've figured those 3 things out, the last factor that we have to consider is time on drug. And what you see presented is that for each subsequent 12-month block, the risk profile may go up. After sharing this information with Matt, the group decision was to move past this drug and to consider other ones. And I understand that. Matt decides, in looking through everything, that he wants to be aggressive. He doesn't want to have attacks. He doesn't want new spots on his MRI. And he sure as heck doesn't want to have new disability progression. He shares that he is not risk averse and that he is willing to do what he needs to do in order to shut this disease down. And he also shares that he's not afraid to take shots. And so he concludes, after reviewing the information, that he would like to start the monoclonal antibody daclizumab. Much to my chagrin, I have to share with him that the way the American FDA wrote the label, it requires that you have an inappropriate or inadequate response to 2 DMTs before you can go on daclizumab. And so we're going to have to table that option, although I share with him that we may revisit it in the future if need be. Given this not being an option, Matt goes to his second choice, which is to start the pill fingolimod. He completes his first dose monitoring without a problem. He leaves the office and comes back 4 months later. He's working full-time as a teacher. He's driving on the weekends. He's taking his pill once a day, and he's tolerating getting his labs. He's got his eyes checked, and we're starting to feel like we're starting on the road to improving his disease process. This story about Matt helps us think through not only how we initiate a disease-modifying therapy, but the bigger picture. Talking about goals, life goals, talking about the goals of treatment, and walking through the process of discussing mechanism of action, of discussing efficacy and safety, and then working with the human being to make a group decision. In conclusion, the story about Matt makes a very key point. MS is a disease measured by decades, and you have to have a patient who is an active partner in their own care. You can't rush MS. And you can't rush, in my opinion, the process of making a group decision. Today you saw an example of how we talk through treatment selection, discussing the mechanism of action, talking about the efficacy and the safety, and then working with the human being to find a drug that's going to empower them, that's going to make them feel comfortable and confident, and be an active partner with you in taking that drug, adhering to that drug, and participating in the monitoring, with a goal of slowing the disease down, with a goal of making them the most awesome person they can be with MS. Thank you.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at www.peerviewpress.com/KSZ. This activity is supported by an independent educational grant from AbbVie.